Hello, everybody. Welcome to the CIN webinar, Understanding Risk-Based Payment Models. This webinar will feature an overview of payment models in play in healthcare today, and it's a preparation webinar for those who will be in attendance at the March partner meeting. My name is Marie Hubbard, and I'm the project manager for the California Improvement Network. For those of you that aren't familiar, California Improvement Network, or CIN, is a network of quality improvement leaders focused on innovation in healthcare. It's a program funded by the California Healthcare Foundation and administered by Health Force Center at UCSF. A few logistical reminders: everybody will remain on mute for this hour. If you have any questions, please feel free to put them in the Q&A function at the bottom of your screen or the chat box. This webinar will be recorded, and at the end of the webinar, we will share both the slides as well as the recording. Just to kick us off here today, an agenda for our time together. Hunter Gatewood, who I'll introduce here in a minute, will go through the topic overview and the objectives for our webinar. Then he'll introduce our presenter, Emma Hu, and she'll talk about payment models in play, risk-based payment, and how it all fits together. We'll also include time throughout this hour for discussion and questions. So now I'll hand it off to Hunter Gatewood, who will be our facilitator. He's a CIN Program Office Senior Advisor, and I'll let you take it away.
Great, thanks, Marie. Hi, everybody. Glad to have you here. We're really happy to have Emma. Thanks for all her work so far in pulling this together. She worked hard with us to organize the complicated world of payment models and parse terminology and all that good stuff that you'll see here with us in this hour. She is the director of Pay for Value at the Pacific Business Group on Health, and so in that organization, in that role, a lot of her work is helping purchasers, so large employers, the people that where the money comes from that pays for healthcare, help them understand what they're getting for their investment, what they're paying for, and how to drive value with their dollars in their relationships with as purchasers with payers and delivery organizations. So she's definitely an expert, and we've worked with her to make this a good summary of the different models we have in play. These are the outcomes we have planned, things we want to happen in this hour, that you will learn more about payment models than you knew before, and covering the main categories I'll show you in a second. What's in play in California specifically, the mechanics, how these relationships work, how these business relationships work in the different payment models with all the different types of organizations that are involved in delivering and paying for healthcare. Some of you on the line, I looked at the attendee list here, some of you will be with us, some of you are CIN partners, the leads in your partner organizations for the smaller network of the CIN, and will be with us on March 13th in Los Angeles for our partner meeting. For you folks, we want this webinar to serve as an introduction to these terms and help set up that in-depth discussion we're going to have about managing total cost of care and risk-based payment, specifically that type of payment arrangement that we'll be talking about in that session. We have Mitch Katz, formerly of LA County and before that of San Francisco, who's now the head of health and hospitals in New York City. He'll be our guest speaker, our main keynote speaker for that meeting. So it'll be a good one. We also hope, I'll mention this again at the end, we are recording this webinar, and there's another great resource that I'll announce that's in play to help educate others in your organizations, people you work with who need to know more about payment models. We hope you use this webinar to as part of your work educating other folks who need to know more about payment models. All right, this is the framework of multiple frameworks that are out there that we are using in the California Improvement Network, and that we asked Emma to use to organize her presentation here today. It's from the HCP LAN National Expert Group. That's part of that's a project of the federal government with some private partners through HHS. These are the 4 categories we'll walk through: throughout this webinar. So this is kind of our roadmap for the webinar. As part of demystifying payment models, for those of you who may be newer to all these different terms and the different models, we wanted to share with you real quick that are actually currently in play in California, in between the safety net and also in the commercial side of healthcare delivery, so that you to help just ground this and make it a little bit less scary if you're someone on the line, or you share this later with someone who has not talked about payment models before and has been happy not to have to not to have to know much. We can't run from it anymore, QI folks like myself. So it's important for us to invest and learn more. So I'll run through these models. Then we'll do a quick poll about what payment models are in play in your organizations, and then I'll turn it over to Emma. So if you look here, category 1, fee for service, everybody knows what that is. That's the baseline, that's the old traditional way. We have some of that in place still, of course, but I'm going to start here in category 2, fee for service, with a link to quality and value. So when we look at foundational payments, investments in infrastructure, a really good example of that is the high-tech incentives that just sunset. Those came about, that started in 2009, and it did a lot of things, that federal legislation. But one thing it did was invested in EHRs and using health information technology. Another example, pay for reporting, a lot of P4P programs, including the large, multifaceted 1115 federal waiver, Medicaid waiver, for a lot of organizations, including the county delivery systems. There's a lot of measures in there that are pay for reporting. So you don't get you get the money if you get the incentive money if you send in data. Doesn't matter if it's good or bad. Pay for performance, everybody knows what that is. It's part of your payment mix, no matter who you are at this point. Health plans do that. IHA has had on the commercial side, has had a program going since 2001. So that's a good one to look at. Their program, I just looked it up, covers 9 million California lives across nine commercial health plans. Moving along to category 3, these are alternative payment models, APMs, that are built on top of fee-for-service and have some level of shared savings and also some financial risk. Again, Emma will explain what all this means, but an example is at the partner meeting on March 13th, Jania Fick from Inland Empire Health Plan will talk about a pilot they have going on with their Medi-Cal managed care provider network that has some shared savings. There's other good examples in the commercial market where it's been more common longer. And then downside risk, if you know about accountable care organizations, the next generation version of ACOs do have this particular payment model in play. Fourth category in our framework is population-based payment, where unlike the category 3, the money is attached to the people whose care is covered, versus specific types of versus the services. So examples of these: medical group specialty subcap, which Emma will talk about. Some of you may be familiar with that. Capitation, the comprehensive population-based payment. That's another way to talk about capitation payments, where the provider organization or the provider gets a set amount per person, and they need to manage all the care within that. And then finally, full risk is an example of this last category within the population-based payments. Healthcare Partners and Sharp here around me here, I'm down in Southern California, are some examples of the many where full risk is happening. So that's a real quick overview of the framework and some examples of things that are happening in California. All right, so now we're going to do a poll. I'll leave it here on Emma's slide. Marie, can folks see the poll? There it goes. So pretty much all of you have 2 or more of these payment models in play. Would you please click on your screen here? You can click as many as apply. We want to see what you already have going as a proxy for your knowledge going into this. Okay, about 15 more seconds here. It's a good mix of, yeah, fee-for-service, capitation, pay-for-performance, and surprised to see P4P as low as it is here. Some shared savings, good, that's important. Newer to some folks on the call, as we imagined, and then don't know. Oh, and that's, never mind that. So capitation is the biggest one, and then fee-for-service. And Emma will talk about the relationships. Part of course, what we're seeing in the poll is reflecting what type of organization you work in, depending on where you sit within the healthcare ecosystem. That determines what payment models your organization has in play. All right, thank you all. We can take the poll down, and then I will turn it over to, does everybody need to click out of the poll themselves, Marie?
No, we can just keep going.
Okay, great. So with that, I'm going to turn it over to Emma, and Emma, I will advance your slides as you go.
Great. Good afternoon, everyone. I'm pleased to join you today and share some of the perspectives that I've gained over the years. By way of background, I spent 10 years in a capitated medical group, so share with you the familiarity of having to manage within that budget environment. Today, we're going to talk through a different set of combinations of how some of the payment strategies are evolving. And you go to the next slide, Hunter, talk about the different parties that are part of the equation, in many ways sharing risk, often in varying degrees. In some cases, 3 partners may be working together out of these 4 player groups. In other cases, it may just be 2 on 2. So we'll talk through some of the variations and combinations and some of the incentives that might underlie different arrangements that support higher or lower levels of risk for each party. The next slide. We're going to start with category 2, very briefly. I think many folks are familiar with the types of payments under fee-for-service, and many of you indicated participation in pay-for-performance programs. And in each of these categories, there's a progression around the level of risk that is undertaken and also the set of requirements. One of the things that we see very commonly today are base payments that might be added on to fee-for-service that support care management, for example, a per member per month care coordination fee, or specific payments that might support IT investments, as Hunter mentioned with respect to the high-tech program a few years ago. We are also seeing pay-for-reporting initiatives that often are designed to incent improvements in data capture and reporting, but also in some cases it's to engage providers in adopting more advanced measurement approaches. For example, the Alternative Quality Contract in Massachusetts pays some providers for reporting data on patient-reported outcomes so that it is an incentive to have the providers report the data without penalty for the actual performance measurement results. And after a period of time with benchmarking and feedback, then there's an opportunity to progress towards using the measures for accountability. And pay for performance, many organizations are familiar with the AMP program that is managed by the Integrated Healthcare Association here in California for the commercial ACOs. We also, of course, have pay for performance programs in the commercial ACO programs that are administered by health plans directly with medical groups that mix quality gates for groups to then qualify for shared risk savings, which moves into the next category of payment types. But oftentimes the pay for performance is a set budget that links to quality results. The next slide. with respect to pay for performance, there's a mix of how the dollars are allocated for funding the pay for performance. In some cases, it may be set as a target amount. In other cases, it may be a reduction in the fee for service payment in the form of a withhold, so that the dollars are pooled for distribution at the end of a reporting period. In some cases, the allocation may be based on membership or some other administrative allocation based on a negotiated dollar amount. Next slide. With respect to pay for performance on the physician side, in each of these slides, we'll talk about the different segments or players and how these elements of payment roll out for those individual perspectives. From a physician perspective, one of the key considerations is the pay for performance. What is it measuring? Is it specific to overall total cost of care, or are there specific components that are limited to narrower risk bands and limiting the elements for which a provider organization may have downside risk? In many cases, the pay for performance, may be just an incentive for improvement in quality, such as the measures that are used today in the IHA program. We, see, the improvement over the years in clinical quality measures, patient experience. But we also, in some cases, see agreements between purchasers and health plans, or purchasers and provider organizations, around customer service, access, claims processing, and other types of measures. And in some cases, there may be payment tied to them, or there may be threshold requirements that they have to be met before other payments are released for quality improvement. One of the key considerations for provider organizations and physicians is the exact methodology for calculation and the extent to which the results are blended across organizations or pooled across organizations to distribute payments. Another element is the timing of the calculation and the payments. From an organizational perspective, it's often desirable to provide quarterly feedback and more frequent payments in order to have physicians and providers recognize the benefit of the incentives and have an ongoing opportunity to communicate about the pay for performance program. But at the same time, from an administrative perspective, oftentimes it makes it simpler to have a single annual claims run out and analysis. And of course, many of the clinical quality measures rely on a full year of benefit eligibility for calculation. And so oftentimes there's a lump sum that appears well after the measurement period. And sometimes it's challenging to communicate with providers to connect the dollar payments with a particular period of performance because of the lag time. So at the end of the day, it's important to create aligned incentives across the provider organization, and for those provider organizations to align the measures that they may have for incenting individual providers. Another key component is the extent to which organizations allocate additional monies as part of their capitation or other revenue to enhance the dollar value of the pay for performance. Oftentimes, if the portion is very small, it really doesn't register from a incentive perspective, where if we see increases in the total of claims paid, it captures both the attention of the physicians and also their desire for ongoing feedback and benchmarking information from the provider organization. Next slide. So
great, thank you. Oh, this is going to be this is our first pause for questions. Do we have any? So we're going to take one or two because we do have a lot to learn from Emma, as you can see, she's going very technical, which is what we asked her to do. Do you have any questions about the terminology she used, or anything at this point specifically about this category 2? Pay for performance, pay for reporting, how it works. We're going to keep you on mute because there's over 40 folks on the line. So if you want to chat in, Marie can read those out. Sorry, Emma, were you going to say something else right then?
Oh, no, that's fine.
Okay.
So we have one question from a panel, from a attendee about a list of available, a list that's available of the acronyms that we're discussing on this webinar today.
Great, I'll take that. There will be, so what I'm going to announce at the end is that we do have a lexicon of terminology about payment models that's being written by a colleague of Emma's at Pacific Business Group on Health as another product, another resource from the California Improvement Network. That will be coming out, and we do not have one that'll be sent out with this recording. Except that you should know that if you look up the HCP LAN framework, this framework, the diagram of which we're looking at right now, there's information on that website about these terms. But yeah, I appreciate the question. That's part of what we're trying to do here, is help people understand the difference between all these different terms, and making sure we don't lose people in the acronyms is important. If there's any that come up on this call, please chat those in. If there's something that you don't recognize, that we don't define, please catch us on this as we go in this hour.
I see another question around who is still doing fee-for-service. Surprisingly, there's still quite a lot of fee-for-service. Oftentimes, even in a capitation environment, the underlying payments to specialists may, in fact, be a discounted fee-for-service model that is managed within a provider organization. But we also, in many of the benefit designs that are not HMO, see fee-for-service payments. And for large employers, in recent years, there has been a consolidation of carriers and consolidation of health plans offered by employers, such that they're often creating a fee-for-service chassis over which they are offering a preferred provider network. And in those circumstances, it remains typically fee-for-service. We do see many employers also working with their carriers on accountable care programs, where in some cases health plans have attributed members to specific organizations, such as the organized groups in California. But we also see nationally, in some cases, that the attribution is occurring behind the scenes, and the medical group, it doesn't exist in the organized fashion that we see in California, and they are organized more for calculating a target budget to pool a number of people together for risk, rather than actually being integrated in a medical system or sharing services in a medical service organization. We also, do see in those environments that the fee-for-service might, have a withhold to support the pay-for-performance, but oftentimes it's still the, traditional volume-based kinds of payment.
Great, thank you. And Amy Peterson, hello, thank you for your question. Emma, I want to share something that I've learned over the last couple of years that I want to see if you agree. I've heard that from Suzanne Del Banco at Catalyst for Payment Reform and other folks, it's maybe not the, as the models evolve, as payment models evolve, that the future models, especially definitely current models, but also future models over the next few years, the resulting models that people might stick with for a few years will be some mix. It's not that we're going to leave fee-for-service behind altogether. for all types of services, you know, like you said, specialty, primary, hospitals, professional fees, all that stuff. The eventual model, or the model that people are building towards as an ideal model in different situations, will probably include some mix of fee for service. So maybe category 1, 2, 3, and maybe even 4, but that it's not about moving from one category altogether to another, or to another mix. Do you agree with that?
That's right. I think in some cases, some specialties might lend themselves more to capitated payment or population-based payment, where others that are less common, that involve specialty referral services or external contractors, it's more difficult to predict the cost because of the lower frequency of services or the limited number of providers.
Great, thank you. And then one more question I see, and then we'll move on to category 3, because I want to give Emma her time for sure. So Bridget, hi Bridget, is pay for reporting also typically an annual payment? And then Prime, Emma, if you're not familiar, Prime is one of the programs, one of the many programs and structures within the 1115 waiver through the federal waiver that the state got from Medicaid. But her first question is, P4R typically an annual payment?
I think P for reporting can also be more frequent because the data feeds may be either monthly or quarterly, so it varies considerably.
Right. Okay. Thank you. All right, let's move to the next category. Oops, sorry. Advanced too far. Oh, no, there it is. Okay.
So we're moving into category 3, which includes risk-based payments. And since many of you overwhelmingly indicated that you had familiarity with capitation, I won't spend a huge amount of time on the capitation structure itself in this context, but I think one of the areas that we've seen considerable variation on over the years is the degree to which there is upside and downside risk with respect to payments. With upside risk, if a target is met, there typically is no direct penalty for not meeting a target, and the savings may be shared based on that target being met. If the total cost of care is below a budgeted target, the groups may split the savings, or in some cases, the savings may be allocated based on the portion of the budget that's represented by professional, hospital, and pharmacy and other services. With respect to downside risk, often, this is driven by costs exceeding the targeted budget, and the provider absorbs that differential. In some cases, there might be a tiered structure where, depending on how far the target was missed, there may be higher or lower degrees of penalty. And in some cases, the penalty itself may be capped because it's challenging to have significant swings that could be occurring year over year. In some cases, because there is a withhold that allows for some budgeting of the monies, it results in just a lower distribution of those dollars, as opposed to a payback that has to occur at a specific period in time. In some cases, a medical group could be paying a plan or a hospital partner. In other cases, if the hospital partner is also at risk, they may share in that downside. Next slide. So with respect to shared risk and savings, it's important to think about the portion of the risk that's actually being shared. Many years ago, when I worked in a medical group, total risk was pretty common with downside risk, and we had a lot of challenges financially in California that resulted in the financial solvency regulations and consolidation of a lot of provider organizations, as smaller organizations found it very challenging and volatile to accept downside risk. And as we also saw the portion of hospital costs increase as part of the total premium, there was often less desire by provider organizations to accept risk. And so the distribution of the savings depends on the allocation across different organizations. In some case, the shared savings may typically be negotiated just between the medical group and plan. In some cases, it's between the medical group and hospital, so that they both have aligned incentives around managing discharges and readmissions and facilitating coordination to lower cost sites of care like SNF or subacute. In some cases, we see a arrangement across the medical group, hospital, and health plan, or in some cases through direct contracting with purchasers themselves. There are regulations in California that limit the downside risk in that direct contracting arrangement, but in outside California nationally, there are a number of instances, such as like Boeing in their contracts with their ACOs do have a target performance budget that looks at total cost of care, and there is downside risk for the provider organizations, as well as a number of quality measurement requirements. When we look at the broader picture, it makes sense to bring all the parties together, because then everybody has a stake in managing to those targets, and incentives are aligned across the various organizations. In setting up the contracts, it's important to think about the types of services that are included as well as excluded from calculations. We've seen a number of instances where high-cost medications may be excluded. In other cases, prosthetic devices might be excluded, but that creates more challenges because it reduces the dollar that is managed together across the organizations. In some cases, the hospital, for example, might have a group purchasing arrangement that lowers their costs for prosthetic devices, and that can be a shared incentive across the specialists within a provider organization to engage in selection of a common prosthetic vendor. But if it's excluded from the calculation, then nobody really has an incentive to change the structure. And this is a similar dynamic that occurs in the bundled payment models that are now taking a lot of attention from CMS through their pilot programs, where a lot of the focus has been on managing the contracts, setting up more reduced rates for home health, or reducing the number of days in skilled nursing. But there are still additional expenses that could potentially be more effectively managed if all parties had a stake in the game. One of the other components around shared risk and shared savings is the extent to which there are requirements to meet quality or financial thresholds. In some cases, a group may moderate trend but still not meet some of those thresholds, in which case it feels like a penalty because there is a set of dollars on the table that a provider group or hospital don't have access to because they haven't met the targets. But it's important in a fixed budget environment that we have these quality thresholds and incentives, because we don't want any stinting or passing the buck, if you will, on services that would otherwise be provided as part of a coordinated set of services. Some of the other approaches to managing the degree of risk is that organizations may negotiate a cap on the total dollar that they're at risk for, or that there's a corridor so that, plus or minus 2%, just to throw out an example, the dollars aren't moved around because that can shift, year to year by a tiny amount, where in a negotiated arrangement, the savings may need to exceed a certain dollar amount of, let's say 4%, and then there's more dollars that can be moved around and more opportunity for a bigger portion of the savings. So there's a number of these elements that can be negotiated, and later on in the slides and also in the appendix, we have discussion of some of the provisions that underlie these shared risk arrangements, including the division of financial responsibility, as well as discussions around stop loss that might set limits on the cost of any one case being applied to the total cost of care for that pool. Next slide. This is just an illustration. I won't spend a lot of time going into the detail, and just in the interest of time. But this is just taking a simple math calculation of looking at the component elements, where in this instance the actual expenses exceed the target, but in this case, there's also a credit for excluding some of the large cost claims, the jumbo cases that might stem from an acute event. And then some of the math that shows what a gain sharing arrangement might look like, and different scenarios for applying the stop loss, and if the cap amount is triggered, and what that means in the ultimate dollars that are being shared. Next slide. With respect to shared risk, I think probably one of the most common designs we see in California is shared risk between the medical group and health plan. We have seen this also a lot in the Medicare Advantage space. One of the challenges, as I noted earlier, was the financial risk that was undertaken by groups that maybe were not large enough or did not have sufficient financial reserves to manage that downside risk. And at the end of the day, we learned a lot of lessons from that period, that it's important to have the alignment of incentives across the medical groups to manage the high cost areas, like avoiding readmissions or ensuring primary care access at off hours or weekend hours to reduce emergency room visits. One of the other considerations in coordinating is that oftentimes if a medical group and plan have the shared risk arrangement that doesn't include the hospital, then it creates a separate incentive where if a hospital has a large rate increase, the hospital benefits directly, but then it ends up being a additional risk element for the medical group, because the medical group doesn't have control over that rate increase. And even if they manage utilization to a target, the total dollars may put them over the target budget because of the relative portion of the rate increase. So a key takeaway from this is, what is the method for setting the annual trend? Does it include the expected rate increase for the set of contracts that are up for renewal in a specific period? Does it exclude certain high cost elements? I think many of you may have read in the popular press about some of the new cancer treatments that are coming down the pipeline, like CAR-T, that can be $1 million in and of themselves and have curative impact. Those are examples of new technologies that are difficult to predict. We've had a lot of experience with situations like transplants that often a health plan might have a center of excellence for that and exclude that cost, or at least have a more predictable cost for managing that case. And then lastly, as noted before, what level are the quality thresholds set at? Are they regionally based? Are they benchmarked across the similarly situated groups? Are they statewide, or are they tied to a national benchmark like NCQA 50th percentile or 75th percentile? So a group has to understand where they stack up currently in terms of how achievable those targets are. Moving on to the next slide. These are just some additional items where, if the shared risk arrangement does include the hospital, it makes more explicit the opportunity to align the incentives and to manage to a common goal. Next slide. So back to the original slide of thinking about the partners that are in the arrangement. Having 2 or 3 parties to a shared risk arrangement, creates the chain of incentives that can either be working in concert or in opposition. And at the end of the day, for the shared risk arrangements to work, it makes sense to have all parties rowing in the same direction. Next slide.
Great, thank you. Thank you for covering so much so rapidly. This is great. We do have we're only going to have one question or comment here, request of Emma, to cover category 3, then we'll move to category 4 and have more discussion as much time as we have left. So I don't know if you can see in the chat here, Emma, but Bob Moore from Partnership Health Plan of California would like you to comment on a situation where a financial or business folks, or those part of the organization, negotiate a risk or capitation arrangement, which theoretically aligns incentives, but frontline staff and providers don't change any behavior based on that arrangement. What's the best way to monitor for aligned benefit for such arrangements?
That's an excellent question. Hi, Bob. I think the big challenge here is that it's easy to have the contracting folks together in a room negotiating each component of the letter of the contract. But the lesson I take from that is that it's important to bring providers into those discussions. The example I gave earlier around the prosthetic devices for orthopedic services in bundled payment, logically you would bring the providers together and talk about, is there an opportunity to create savings there? And if it turns out that the providers are really married to the equipment that they use and absolutely will not sit together down at a table to talk about making changes to create efficiencies and money, then maybe that's not a place where an organization wants to take financial risk. So I think part of that is the communication and planning, and I think it is very easy for the actuaries and the contract negotiators to get into the fine lines of negotiating dollars and cents without connecting the impact on workflow and whether it's actually feasible in a clinical environment to make modifications. And I think in some ways it's helpful to bring the providers in early in the stages of discussion to identify where are the waste reduction opportunities and to think about how those can be integrated into a contract, because it may be measuring more the utilization changes for a particular type of service, or changing a site of service from infusion, in a doctor's office versus hospital setting, those types of changes, as opposed to wholesale changes that are not bought into by the providers themselves.
Great, thank you. Yeah, highlights the issue that we're not absolutely certain for a lot of these models how much they do drive value, right? That there's different levels, and there's a lot of research in that we will not go into today, but some of this is, to me, seems like it's still in the experimental phase. Okay, so last category, Emma, thank you.
What I'll do here is talk at a high level of some of these examples. I think many folks are familiar with capitation based on the experience here in California, insofar as it's been very commonly in use for many years. We have seen specialty capitation come and go. I think for larger organizations that have the predictability of a panel of, let's say ophthalmologists or dermatologists with a certain amount of volume, it may be feasible to do specialty capitation, but it's certainly harder in an environment where there may be more variation just due to population mix or geography. But it's certainly a way to bring providers together at the table. I can remember meetings and discussions, where when dermatologists got together and accepted capitation, then they had an incentive to train primary care physicians to recognize simple risks around skin cancer identification and not send the routine moles to the dermatologist, where in other instances for orthopedics, it creates an incentive for the orthopedist to manage the extent to which they're ordering MRIs or CAT scans and so forth if they are at risk for the total cost of services, and also to be more proactive about seeking referrals for physical therapy or other interventions than surgical. So it creates a different set of dynamics in terms of incentives, but you need to have sufficient volume and engaged specialty providers to manage that effectively. With respect to the integrated delivery systems that are able to manage full capitation, it's actually in some ways surprising that this has become pretty rare in California, though I understand anecdotally that it's making a comeback, especially with the alignment on the Medicare fee-for-service and opportunities in Medicare Advantage, as well as the commercial ACOs, that in order to create the volume of reporting across all lines of business, that in some sense it makes a common incentive to align the structure of contracts across the various payer categories. And so it, at the end of the day, creates the opportunity for more shared information and better management from the perspective of care coordination, because everybody has an incentive at the end of the day and has a share in the opportunity for reducing the costs and gaining from the shared savings. One of the benefits of being California, of course, is that, because we've had the long-standing performance-based program, providers in California are very much accustomed to the quality measurement and reporting. We've had for many years the collaborative processes in California to agree on common measures, as well as specific approaches to data collection that are administered through the Integrated Healthcare Association. We've at PBJH continued to administer the patient assessment survey. So in that environment, have also worked with organizations to evolve that instrument to try to increase the response rates and continue to emphasize the patient experience as a component of quality measurement. So I think, we're happy to say in California, we don't have many instances where there's no link to quality when capitation is used. Next slide. The episode or bundled payment, I think, is something that is getting a lot of attention these days, in part because of the bundled payment program that CMS introduced initially as a voluntary program, and then with a set of mandatory regions that were undertaking bundled or fixed payments for orthopedics. We saw the effort to develop a similar program in cardiac, only to have it canceled, though in the very early days, there were programs around cardiac that were highly successful under Medicare. In some cases, we are also seeing organizations undertake risk for oncology, and coming down the pipeline is also a radiation oncology bundle that's under development at CMS. The intent is that a bundled payment looks at a specific line of care and line of service that creates opportunities for a coordination that is higher across that episode of care because of the specialization that's involved. For many years, we've had case rates in maternity care, and in its simplest form, it is a portion of a bundle. But the idea of an episode-based payment is to bring together all the professional, ancillary, and hospital-based services into a longitudinal episode of care so that everybody is engaged in the care process, the diagnosis, the shared care plan, the decision-making by the patient, and so forth. So at the end of the day, the opportunity is to create better outcomes at a lower cost across the system. Again, many of the same issues apply here around, what are the time frames that we're measuring? Is it, 30 days before, 60 days after, and so on. From a purchaser perspective, we'd like to think about the entire episode of care, because from a patient perspective, it really is from the diagnosis to the treatment, but oftentimes a patient may be accessing different sources of providers for that care, and managing that episode becomes challenging when the portion of providers that are involved increases. And in rural geographies, it can involve moving around to different health delivery systems and different sites of care, versus an urban center where some of that might be concentrated in a single medical clinic. We have had some early experience, and in the Medicare space, we definitely saw some positive results in orthopedics. In the cardiac space, there were some general positive results for certain conditions, but the number of episodes that allow for pre-planning in the cardiac space is more limited than, say, a joint replacement. But again, at the end of the day, it creates opportunities for gaming of the system in how cases are counted or excluded, whether there's risk adjustment that underlies the arrangements, or how individual complex cases with multiple chronic conditions might be excluded. So part of the challenge is, how do we manage as a system and not, create fragmentation by selecting different components and separating the services that may be less predictable, and therefore make it more difficult for providers to manage that component or risk. Next slide. I won't go into this in detail because I think everybody's familiar with it, just in the interest of time. But I think we know that there's some various flavors of capitation in terms of what's included. Next slide.
Okay.
The global budget total cost of care, I think this is the area where purchasers really have the most interest, and looking at the issue of how do we integrate across the system. We sort of created our own mess in terms of adding various carve-out services, mixing and matching vendors in the space, that it really makes it harder to aggregate that information into understanding the total cost of care. And at the end of the day, looking at total cost of care, not only from the care system perspective, but also the impact of outcomes, return to work, is really what an employer needs to be thinking about. And as the provider structures have evolved in California into integrated systems and more alignment across provider systems and hospital systems, it in some ways makes it easier to look at total cost of care. But it's an area that still involves a lot of complexity in how we count the total cost of care, whether it's a population-wide basis, or if it's specific members that are assigned to a specific group that are counted in terms of a budget target. Much of the work that the Integrated Healthcare Association is doing to look at total cost of care, helps bring these elements together. Especially as the pharmacy component has been growing as a portion of total dollar, and also the medical component of pharmacy spend with biologics. It's really important to bring these elements together and improve the data that we have to understand all these component parts. Next slide. With respect to the risk assessment, risk adjustment, this is a very complex, in the weeds element of, how do we adjust the capitation to recognize the morbidity of the population. A population that has a higher rate of diabetes or cardiovascular disease needs to have a larger budget associated with it than a group that is a healthier population. From an employer perspective, we see vast differences between government or energy sector versus retail, where it's a much younger population that has a lot of turnover. And so in this process, in thinking about overall capitation, the mix is important. The volume of workers that are female in a banking or retail environment is important, because even though a chronic disease, the maternity costs can be a huge portion of total claims. So there's a lot of reliance on risk assessment and regional benchmarking in many of the Medicare models. But at the end of the day, it's important to recognize that the predictability is only as good as the data that you have to aggregate and analyze. And at the end of the day, at the individual level, it only really predicts the cost 25% of the time. So it really has to be applied to a broad population. Next slide.
Great. You did it. Thank you, Emma. You covered all four models, or at least the categories 2, 3, and 4 here in our hour that we had. Thank you for your work. Again, you worked hard helping us get to this concise presentation. I am going to skip ahead to the wrap-up slides, but everyone should know again that we will have this recording available to you. There's all these additional slides that we'll share with you, including the division of financial responsibility and some of the other information that are really important to the mechanics of these models that Emma described that we did not get to talk about today. So the recording will be available. The slides will be shared. Again, like I mentioned before, Saida had a good question about acronyms. Acronyms and these terms will be in the lexicon that we're working on as a new CIN resource. To get the lexicon, find out other things happening with the CIN. If you're not yet getting emails directly from CIN, please go to chcf.org, and under the Our Work section here, you can see on the CHCF homepage is the way for you to find out more about the CIN and click on the Join Now button to make sure you get these resources directly. So I want to thank you all for spending an hour of your day with us. Marie, I think you've launched the survey here. There we go, a survey. Please give us input if you have another minute to spend with us to let us know how this worked for you today, and wrap that up. Again, one more time, thank you so much to Emma Hu from Pacific Business Group on Health, sharing just one small part of her expertise, as you could tell, with us in this orientation to payment models. So with that, we'll leave the poll up for another 30 seconds or so, and then we'll let you get back to your day. Thank you.
Thank you, everyone.
Thanks, everyone. Thank you, Emma.